We got one more person coming in and then we can start, Dr.
Tell me
Miyaki.
when.
Okay.
No problem. Tell me when. Thank you.
But I just wanted to thank you guys for coming again. And those at home on Zoom, thank you for joining us, taking time out of your busy schedule. And then today we have Dr. Masaki from the Department of Geriatric Medicine, and she's going to talk about healthy brain aging and dementia. I'm so sad we didn't get our last session recorded because that was really interesting. Yeah, Sharon. Okay, I think we have one more person. Morning. Will you come with you? Okay, I must come with you. Okay. Okay. Have a seat and then we'll start as soon as she's ready. Everybody got water? Sharon got water?
It's okay to start. I think I got a message saying it's okay. Shall I go ahead?
Yes, we're ready.
Okay, wonderful. Okay, I'm going to share my screen. And good morning, ladies and gentlemen. Thank you so much for joining us again and spending your time to get educated about healthy brain aging and dementia today. I'm from the Department of Geriatric Medicine at the John A. Burns School of Medicine, University of Hawaii. So I want to start with a sort of dramatic statement, but it's actually true, that Alzheimer's disease is a public health crisis. We have almost 6 million people currently in the United States living with Alzheimer's or another type of dementia. It's the 6th leading cause of death across all ages, and 1 in 3 seniors will die with some sort of dementia. So this is a very serious problem. And the government has really sat up and taken notice over the last 5 to 10 years because they really poured a lot of money into research and education for dementia. I'm going to start with the good news. Healthy brain aging. Are there ways that we can actually prevent or try and at least delay the onset of dementia? Well, this is what healthy brain aging is. We all want this as we grow older. We want to continue to have the ability to think, reason, remember, carry out our tasks and live our lives, function independently, keep our social connectedness with our family and friends, and keep our own sense of identity. However, there are some changes in the aging brain, even with normal aging. Some parts of the brain shrink, and this is especially true for the center responsible for memory, and this is called the hippocampus. And it's actually a very tiny part of the brain. But when they've done repeated MRI or other studies looking at the same person over time, they found that over time, this part of the brain shrinks. And we do notice a slight decline in the ability to learn new things. So for example, I've had patients who, they never got to go to college because they grew up on a plantation and right after high school, they had to go to work to support their family. But now that they were retired, they want to go back and do some adult education. I'm sorry, could everybody mute yourselves, please? Because I'm hearing a lot of background noise and that's going to come on the video as well. So if everybody could go in and mute yourselves, that would be really great. And then we'll unmute during the question and answer. Thank you. Anyway, as I was saying, I've had patients who've gone back for adult education and they've come back and told me, I can still learn, but my memory is not the same as when I was 18. I could remember things, memorize things a lot better then than I can now. So we do notice that slight decline, but you can still learn. And older people tend to have a difficulty in multitasking. But certain other things actually get better with age. So things like vocabulary, problem solving, the things we call wisdom, actually get better with age. So these are the factors that are important in maintaining brain health. We know it's important to be physically, socially, and mentally active, to have good nutrition, and also there's a big heart-brain connection. So if we reduce risk factors for heart disease, it also will have some preventive effects for brain disease. I'll go over each of these individually. So when we look at physical activity, we know it has beneficial effects on lots of different parts of our body. So it reduces risk of diabetes, high blood pressure, heart disease, stroke, even depression. People who are more physically active have less of these. We also have found, though, that physical activity is good for the brain. We know that it may help improve the connections between the brain cells. So it's really important for everyone to find ways to exercise safely and regularly. And so check with your doctor. Don't go run a marathon without checking, but it's really important to do that. Mental activity is also important. So it's important that even after retirement, we continue to do things to stimulate our brain. So people often will ask me, what exactly should I do? Well, there is no magic bullet. There's nothing that's been proven to say, if you do this, it will prevent dementia. And actually, some people advertise that way. I've seen books advertised, read this book or do this puzzle and you won't get Alzheimer's disease. And really, that's not true. I don't think there's any particular activity that's been proven to prevent Alzheimer's. But we do know people who are mentally active do better. So I say pick something that's interesting to you. If it's reading, playing games, doing puzzles, whatever it is, do that. That's interesting to you. Attending classes like this one are important too, keeps your brain active, right? Volunteering is a wonderful way to keep your brain active as well. Social activity is also important. So we do have some people who do their retirement and plan really well and remain socially engaged and actually have a lot of fun. They go traveling, they go visit family, friends, and do a lot. And that's great. We also have people who retire and do nothing. They just sit on the sofa and watch TV all day. So it's really important not to do that. We know that people who are more socially active have less risk for many health problems, including dementia and depression. Again, joining a community center or a senior center, really good idea to stay socially connected. Good nutrition. I get asked this a lot. Can I just pop a pill? Can I take this vitamin or this supplement and that's going to prevent dementia? It's not that simple. Actually, none of the supplements have been proven to prevent dementia, but we do know through studies that the Mediterranean diet or other forms of diet similar to the Mediterranean diet can actually reduce risk for Alzheimer's and other forms of dementia. And this is a very common sense diet. Lots of fruits and vegetables, whole grains, lean proteins, less of the bad stuff, less sugar, salt, and saturated fats, and then drinking enough liquids as well. And then this is a relatively new concept over the last 10 to 15 years. And actually, one of our studies here in Hawaii was one of the first to show this, that if we reduce heart disease risk factors, and we have to do this early, don't wait until late life. Many of these problems, particularly high blood pressure, diabetes, high cholesterol, actually start in middle age. And so if we get good lifelong control of these problems, there's a lower risk of developing dementia in old age. The two most important are high blood pressure and diabetes, but also the others, avoiding high cholesterol, avoiding obesity, stopping smoking or not starting at all is even better, and staying physically active, and doing this through our entire lives, good health habits. The CDC has come out with this wonderful document called the Healthy Brain Initiative. You can actually download it. You can just Google it, Google Healthy Brain Initiative and the CDC, and you can get the information. And it has some very good information. Hawaii actually has a state plan on Alzheimer's disease. And I and other members of my department are part of this planning group. And again, there's a link on this slide where you can actually go in and see the Hawaii State Plan. Moving on then to what is dementia. I'll first go through the common myths. The first one is that memory loss is the same as senility or becoming senile, and it's an inevitable part of getting old. I actually looked up this word. I was interested. Senile means old. So if you say old means demented, you're saying every older person has dementia. And that's just not true. All of us know people in their 80s, 90s, and even beyond who are still very mentally sharp. My own mom, she's 89 years old, and I swear she's mentally sharper than I am. So we all know that it's not just aging, it is more than that. The second myth is that nothing can be done for dementia. While I agree that we do not have a cure, and even our treatments are not that great yet, there's a lot we can do. And I hope by the end of this hour, you will agree with me. The third myth is that most people don't want to know if they have dementia. And this is also not true. They've done studies asking older people, if you did develop dementia, would you want to be informed about it? And the majority of people say, yes, I would want to know. So all of these misperceptions and myths actually contribute to the under-recognition of dementia. So what are the facts? First, it is not normal aging. It's actually not even a single disease. It's several types of diseases together form this group of diseases called dementia. It is common. It is underdiagnosed. It's a very expensive disease, and it's also a fatal disease. People do die because they have dementia. And the other fact is that patients with dementia should have a thorough evaluation by a physician who's experienced with this. So the definition then, the first thing is you need to have acquired deficits.
You could
What
have
does
gotten
this
up
mean?
11 after you found what yours.
Oh,
No.
could I
You have to
ask our
put yourself up
audience to
till I need,
please mute yourselves? Thank you so much.
She, I never ordered, but anyway. Yeah. Okay.
Ladies and
Can you give this to
gentlemen,
Lola? Oh, yeah, okay. I wonder if I should drop it off at that. She can eat, yeah.
could you
I can
please
go.
mute yourselves? Because
Yeah, I thought she can go over there.
Michaela, are you able to mute the audience?
Okay, bye. Bye then. Thank you. Yeah, I might be better if I just listen to Amaka, then go home to all annoying. Yeah.
Michaela, are you able to mute the audience? Okay. Okay, let me go on again. So what is the definition of dementia? First of all, it's acquired deficits. What does this mean? This is a change. It's something new. So people who have mental retardation, who were born with that doesn't count as dementia. This is somebody who was functioning fine and now has cognitive deficits. We do need to see a deficit in memory, but not just memory. It needs to be memory plus at least one other cognitive domain needs to be affected. Things like language, visuospatial ability, planning ability, attention, something else other than memory. It needs to be bad enough that it affects your social functioning with your family and friends. And if you're still working, it affects your occupation. So you're not able to function in your job as you were before. And we need to have an absence of delirium. Delirium is an acute confusional state that we see usually in the hospital when somebody's sick with pretty much anything. And mostly this happens in older people. They go into hospital with any illness. It could be pneumonia, a heart attack, stroke, anything. And they're suddenly very confused. And usually this is a reversible condition. So when somebody has this delirium, we really cannot diagnose the dementia. We have to wait until the delirium is treated. Or if they have any major psychiatric illness. So if, for example, if somebody has a major depression right now, we have to wait until the depression is treated before we can say that the person has dementia. There's this condition called mild cognitive impairment, or MCI. This is a sort of pre-dementia syndrome. The person themselves may have a cognitive complaint. So the patient themselves might complain, my memory is bad. More commonly though, it's not the patient, it's a proxy. It's a family member or a friend who'll notice, and the patient may have no idea that there's a memory problem. And we have to see deficits on testing in at least one domain. This could be memory, language, attention, executive function, which is planning abilities, or visuospatial function. Any of these can be affected. But your functioning needs to be normal. So you're still able to interact with your family and friends or work at your job. Because remember, if they had functional impairment, they have dementia. These are people who are normally functioning, but their memory is showing some problems on testing. These patients do have a very high risk of converting to Alzheimer's disease. So these are people we really want to keep an eye on. There's a lot of research happening in this area to see if there's something we can do to prevent the conversion of MCI into dementia. So moving on, how common is it? It's about 13% of people over 65 years of age. But when we reach the 85-year group and over, it's almost half of people will have dementia or memory problem. We see a geometric increase in the prevalence of disease. So after the age of 60, it doubles every 5 years. So I have a graph on that. So if you look here on this axis here below, the horizontal axis is age, starting out at age 60 and ending up at age 85. And these are all 5-year age groups. And on this axis is basically the percent with dementia. Now this blue line here, the lower line, this is people who have dementia that meets all the criteria. So it's affecting their functioning, it's affecting their life. This red line has those with dementia, but it also includes those with the pre-dementia, the MCI. And you can see both these lines, they're not straight lines, they're curved lines that go up quite sharply. And that's because every 5 years, there's a doubling of the rate. Why does this happen? Because this is a disease you live with for a very long time. It's not something that kills you quickly. It's something that goes over sometimes decades. It's a major cause of disability though, and it's the primary reason for being put in an institution, either a nursing home or a care home. In nursing homes here in Hawaii, if you count those who are in long-term care, about 80% of those patients are there because of dementia. A very common problem. Also a very expensive condition. Over $200 billion is spent for direct care and an equal amount for indirect care, which is lost productivity. So think about it. If you've known somebody who has a family member with Alzheimer's, often the family has to make a lot of sacrifices. People take early retirement, or they have to miss their job to go to the doctor's appointments or whatever it is that the patient needs. So families really bear a lot of this cost. Next, I'll move to the subtypes of dementia. I really want to stress this slide. Not all dementias are Alzheimer's disease. Dementia is the umbrella diagnosis. Remember, this is people who have acquired deficits with memory, other cognitive problems that's causing them to not function well in their lives, correct? That's dementia. There are several subtypes. These are the causes of dementia. By far, the most common cause is Alzheimer's disease. And in most studies, it's about 60 to 80% of all dementia is Alzheimer's. And then there are others. I'll go over them in the next slide, okay? So dementia is the umbrella diagnosis. Under that comes many different types of dementia. Alzheimer's happens to be the most common type. So when we look at white populations, this is the mix we see. This pie chart, this blue piece of the pie, that's almost, it's about 2/3 to 3/4 is Alzheimer's. And in white populations, we see by far the most common is Alzheimer's. Vascular dementia is that's related to stroke. And we see in most studies, it's somewhere between 10 and 20%. That's this red wedge, vascular dementia. Then there's this yellow wedge, which is Parkinson's disease and other Parkinsonian syndromes, including this condition called Lewy body dementia. That's a whole bunch of diseases that cause this, a little bit less common. And then there's a bunch that are mixed and other dementias. We do know that some dementias are actually reversible. Not very often, unfortunately, but it is possible. So that's why it's very important to find dementia as early as possible. Now remember, this pie chart This is in white populations. And I'm going to go over some research that we do here in Hawaii ourselves to show that it's a little bit different in Hawaii because we have so many Asian populations here as well. So I'm going to talk a little bit about a study I've been involved with for the last 30 years. It's the Kokini Honolulu Heart Program and Honolulu Asia Aging Study. The original study actually started in 1965 at Kokini. It's the third longest running study in the world. Pretty amazing, right? Right here in Honolulu at Kokini. It started with 8,006 middle-aged Japanese American men, and it really started out as a study of heart disease and stroke. But the shift to aging began in the early 1990s. At that time, 3,700 plus men were ages 71 to 93. So now they were considered in older ages. And at that time, the study shifted focus. We were still studying heart disease and stroke, but now the focus was more to study cognitive function, dementia, disability, and other types of aging diseases. So these men have had examinations over 50 years. It's pretty amazing how they've stuck with this study. So this is prevalence rates of dementia in that study. Again, on this axis down here, the horizontal axis is age groups. The youngest is 71 to 74, and the oldest is 85 to 93 in this study. And on this axis is the percent with dementia. The blue bars is the people who have dementia, which is bad enough that it's affecting all your activities. It's affecting your functioning, your independence. And the red includes the people who have the milder cases, the MCI or the mild cognitive impairment. You can see pretty common, right? About almost 10% and here about 13%. And if you look at the age groups, yes, if you drew a line here, it would be sort of a curved line. So these numbers are very similar to the national numbers. About 1/3 of people over 85 have dementia that's very significant. And when you include the MCI or the mild cognitive impairment, it's almost half. So this is similar to national studies. But this next slide shows how we are a little different in Hawaii. So this is the subtypes of dementia. Here in blue, I have the Alzheimer component, and in red, I have the vascular disease or stroke-related component. Now, if you look at the age groups down here again, if you look at this youngest age group, actually, Alzheimer's is less than vascular dementia. So the stroke-related dementia was more common here. Now, as you go older, Alzheimer's overtakes and is number one by far, especially in this oldest group. But the vascular is not that far behind. So if you remember that pie chart I had showed you, where the big wedge was Alzheimer's and vascular dementia was a tiny little piece, that's not really true here in Hawaii. We do see Alzheimer's is number one for sure, but vascular or stroke-related dementia is pretty close behind. And there are studies from China, Korea, and Japan that have actually showed in some studies their vascular dementia is actually the most common, even more common than Alzheimer's. In Hawaii, we see it's more intermediate. So Alzheimer's is still the most common, but there are many people who have vascular dementia more than in white populations, and a lot of people who have mixed dementia, who have a combination of Alzheimer's and stroke-related problems. Moving on then to Alzheimer's disease. This was first described by Dr. Alzheimer in 1906. It was a case report. He had this lady who was middle-aged. She was actually in her early 50s, very young for dementia. He called it a pre-senile dementia because she was so young. She had very severe cognitive problems, severe behavioral problems. She was actually psychotic, progressed quite rapidly, and within a couple of years, she had died. And he actually got her brain at autopsy and showed the pathological findings that to this day are the hallmark of Alzheimer's disease. So over 100 years ago, this was very well described. And yet, there was very little research into this disease until the 1980s or so. The reason is people used to think this was a very rare disease. Now remember in the 1900s, in the early 1900s, life expectancy was 45 to 50 years. So most people died long before they were at risk for developing Alzheimer's. As life expectancy grew through the 1900s, and it was very common now for people to live into their 60s, their 70s, 80s, and beyond. Now they realize dementia is so common. And with our aging of our population, now it's become an explosion. And that's why there's so much research now being done in dementia. It is the most common cause of dementia, about 2/3 in Western countries. The symptoms we see most commonly are short-term memory loss, orientation, forgetting the date, forgetting the time, forgetting even the place, and then problem solving. These are affected very early in Alzheimer's. Behavior problems are very common. In various studies, 70% to 100% of patients with Alzheimer's, sometime during the course of their disease, will have behavior problems. Can be very bothering for the family. It is a very slow, insidious onset. It's very hard to pinpoint when this disease began, but it's a relentless progressive course until now. And it's a long duration. Some people do progress quickly and die within a couple of years, but for the most part, most people, it goes over many, many years, sometimes even over decades, could be even 25 or more years. The average is 8 to 10 years from diagnosis to death. And these are the changes that we see. So we see some changes in the neurochemicals. These are the chemicals in the brain that send messages between the brain cells. I have a picture right here. We see a deficiency of this chemical called acetylcholine. This is actually the memory chemical. And of course, it's much lower in patients who have Alzheimer's disease. Other chemicals are also affected. And that's why we think we see problems with behavior, sometimes depression and other conditions. In addition to the chemical deficiency, though, we see these two abnormal proteins that are laid down. These are plaques of beta amyloid, and these are called neurofibrillary tangles. Together, these two abnormal proteins basically strangle the brain cells. So the brain cells or the neurons are actually dying in Alzheimer's disease. And you can see this is autopsy. This is a normal brain. This is an Alzheimer's brain. Just by looking, you don't need a microscope. You can tell this is a shrunken brain, right? It's so much smaller than the normal brain. That's because these abnormal proteins are killing the brain cells. There are some risk factors. I've divided them into non-modifiable and modifiable. So the top risk factor that's non-modifiable is age. So far, we have still not found a cure for aging. We're all aging, right? As soon as we're born, we're aging. Age is by far the strongest risk factor. So although I say this is not just age, it's certainly not, because there are many older people who do not have Alzheimer's. You're certainly at higher risk the older you get. The other non-modifiable risk factor that's pretty strong, and it's consistent in different populations, in men and women, in different ethnic groups, in every country, is low education. So these two, higher age and lower education, are by far the strongest risk factors for Alzheimer's. Traumatic brain injury is a little bit controversial. Some studies have found an association, others have not. On the other hand, I do not recommend that you get your head repeatedly pummeled. People laugh when I say this, but there are certain sports where the whole point is to knock your opponent out and to, hit them in the brain, basically. And now there's a lot of attention been drawn to this because of football, because of concussions. We've had these football players who've had repeated concussions. And for all the world, they're testing like they have Alzheimer's disease. They're not doing very well. So I would say, please don't participate in things that give you traumatic brain injury. Of course, if it's accidental, you can't help it. I have a whole slide on genetics that's non-modifiable, so I'm going to hold that for now. The modifiable risk factors, things we can take care of. Heart disease risk factors like high blood pressure, diabetes, very important. We already talked about diet, eating a very good, healthy diet. Avoiding heavy alcohol intake. We know that people who drink heavily, particularly all through their lives, can really damage their brain and it can become irreversible. Depression can also be a risk factor. And then chronic inflammation is another one as well. Moving on to genetics. Genetics actually gets a lot of attention with Alzheimer's. And that's because when they do movies on Alzheimer's or when they have any documentaries or the press talks about it, they heavily focus on this type, which is the early onset Alzheimer's, which is actually quite rare. Less than 5% of all Alzheimer's is this early onset Alzheimer's. These are people who get Alzheimer's disease in their 30s, 40s, 50s. So, they often have young children, they're at the peak of their careers. It's very dramatic, but it's also very rare. This type of Alzheimer's, the early onset, is genetic, very heavily genetic, actually. These families have what we call autosomal dominant genes. What does that mean? If you have that gene, 100% you will get the disease. You will get the disease if you live long enough. There have been 3 genes identified so far. We know there are more out there that we haven't found yet. And there is an association with history of Down syndrome in the family as well. So this type of Alzheimer's is very heavily genetic. The most of what I see, most Alzheimer's that is seen in the community is the other type, which is late onset or sporadic Alzheimer's, which does have a very slight genetic component, but not a very strong one. Family history is a slight risk factor, but remember, there's also, in these families that have this family history, there's also a lot of longevity. And we know longevity is very genetic as well. So if you had mom or dad, grandpa, grandma, your brothers and sisters live to extreme old age, you are also more likely to live to extreme old age. So part of it is if you have a lot of people in your family who live to extreme old age is the strongest risk factor for Alzheimer's, you will have more Alzheimer's in your family. There is one gene that has been found that's been linked to Alzheimer's. It's called the apolipoprotein E4 gene. It increases the likelihood you'll get it, but it does not guarantee it. So you could have this gene and not get Alzheimer's. You could not have this gene and get Alzheimer's. It really doesn't predict it directly. So I do not recommend routine testing for Alzheimer's for genetics. For these patients with the early onset, I actually do recommend that the whole family get tested and that they get genetic counseling. But again, this is extremely rare. What about protective factors? We talked about physical, social, and mental activities. Well, I have some information from our own Kokini Honolulu Heart Program on physical activity. So here we have people, we asked the men about how much they walked. And this was basically distance walked in miles per day. This is the high walking group. These people walked over 2 miles a day, 1 to 2 miles, quarter to 1. And these were the low walking group, less than a quarter mile a day. And then this is the risk of developing dementia. So you can see this is sort of the baseline risk. So these are the people who walked a lot. But as you walk less, your risk of developing new dementia over the next 8 years goes higher and higher and higher. And in this low walking group was almost double the risk of developing dementia. So just simple walking was very protective for these patients. And the same thing for social engagement. We divided people into high, medium, low, and low. So 4 groups of social engagement. Again, the high group did the best when it was looking at developing new dementia. And then as you had less and less social engagement, your risk got higher and higher and higher. And here it's over double the risk in the low social engagement group. Next, I'll talk about why early detection of dementia is so very important. The first thing is there are a few conditions that are actually reversible or treatable. If we don't find them early, they're no longer reversible. And this is such a tragic disease to get. It impacts not only the patient, but the whole family, sometimes for decades. Why not really try and find that, right? And treat it early if you can, even though these are rare. More importantly, though, if you detect dementia early, it improves treatment of all the underlying conditions. So let me give you an example. Let's say somebody has high blood pressure and asthma. Okay, the family doesn't know they have dementia. Now this person goes into their doctor's office and the doctor is giving them these instructions. Okay, I want you to take these medications. I want you to do this diet. I want you to do this exercise. These are the things I want you to do. The person who has Alzheimer's, they have no idea they have it. They're being polite and they're very socially appropriate in the early stages. So they will smile and nod at the doctor, but they're not remembering anything. So how are they going to take care of themselves? How are they going to take their medications correctly? How are they going to do their exercise or whatever else the doctor is recommending? Their underlying conditions, their high blood pressure, their diabetes, their asthma, other conditions are not going to be treated well because they just don't remember. And the family is unaware, so they're not taking care of that person either. So what this leads to is crisis care. These are patients that often end up in the ER because they're not taking care of their underlying health problems well, or they end up hospitalized multiple times. So if we detect these conditions early and we provide support with family and others, we can reduce this ineffective and expensive crisis care, which is, none of us want crisis care, right? We want good care. The other reason for early detection is patient and family education. Again, the earlier you can do this, the more the patient can understand what you're talking about, and they can actually participate in their care. So advanced directives, this is telling your doctor how you want your healthcare done. Yes, I want these tests. Yes, I don't want these tests. I want to be resuscitated. I don't want to be on a ventilator. All of these things need to be discussed when the patient is able to discuss them. Once they hit even the moderate stage of Alzheimer's, often they're unable to make decisions for their own care. So it's really important to pick this up early. Financial planning, again, is really important. There are a whole list of safety issues which I will address later on in this talk. And then connecting the patient and the family to various community services. There's a lot of help out there, might as well get it. So this is another slide talking about our Kukini Honolulu Asia aging study. And I want to explain this a little bit before I go into the details, okay? So this column is people who definitely did not have dementia. This column is people who we felt pretty comfortable had MCI or mild cognitive impairment because we did very detailed tests. And this column, they met our research criteria for dementia. That means the dementia was bad enough that was interfering with their independence. So it was pretty significant, this column. We asked the caregivers, most of the caregivers were wives or at least family members, sons or daughters. And we asked them, does Mr. X have a problem with his memory or thinking? And the answers were no problem, yes, possibly, and yes, definitely. I want you to focus on this no problem, the red. Among the people who had definite dementia, we're very confident because we did detailed testing and they met our research criteria for dementia. 20% of caregivers said no problem with memory or thinking. When you include the MCI group, it's about half. These are people, the family members who are living with them are not even realizing that there's a problem. You really need to look and test. This was even more alarming to me. The same three columns, no dementia, MCI, and dementia. Now we asked, has Mr. X been referred for evaluation of his memory problems? So has a doctor taken a look at them to see what the problem is? And among those with dementia, less than 40%, this is the red, less than 40% had been tested. Among MCI, less than 5%. Doctors are not good at picking this up. They are missing dementia. This was a different study. This was not the Kukini study, but this was a different study that was done here in Hawaii by one of my previous fellows, who's now at UCSF as a professor there. And he did a study in a primary care group practice here in Hawaii. And he actually examined the patients. And then he asked the doctors and even looked at the charts to see whether they had a diagnosis given of dementia in those patients. And what he found is among all patients, 2/3 of dementia was missed. 2/3 of dementia was missed among everybody. Among the mild dementias, 91% were missed. Among moderate, half were missed. Okay, none of the severe dementias were missed, but should we be proud of that? Severe dementia is something that even a layperson could recognize. Even a child could say something is wrong here. Half the moderate were missed, 90% of the mild were missed. Overall, 2/3 of dementia was missed. If you don't look for it, you will not find it, which is why we're doing a lot of education of primary care doctors to recommend to them that they do routine testing in their patients over the age of 65. They don't even need to do it themselves. They could have their nurse do it or their medical assistant do it and then bring it to their attention if there's a problem. But we really do need to screen. So what are the symptoms? Memory loss, of course, is the hallmark of dementia. Usually, the first signs are short-term memory loss. And then later is the long-term memory loss. I think this is one of the reasons why it can fool people. So I've had patients' families tell me, oh, mom has a wonderful memory. She remembers what happened at my wedding 30 years ago, so detailed. That could be true, but the problem is she forgot what she ate for breakfast 1 hour ago. It's short-term memory that goes first. And I think that's partly why, because long-term memory goes later on, in the early stages, it's easy to not realize that your family member has a memory problem. Disorientation, particularly to date, but even to place. What do I mean by place? Well, if you're traveling and you get lost, that's not unusual. I think all of us get lost sometimes when we're traveling, right? We're in a new city, we don't know where we're going. That's not abnormal. I'm talking about somebody who's having trouble getting home from the grocery store 1 mile away from their house, and they've lived in that same house for the last 40 years, and they're having trouble getting back. Even familiar places, they're not oriented. You can see difficulty with naming and understanding, particularly in Alzheimer's, but even in some of the other dementias, you get this lack of insight. So the patient may have no idea they're having a memory problem. In fact, the most common response for a person with Alzheimer's, when we ask them, how's your memory? The most common response is, doc, my memory is great, because they lack that insight into knowing that they have a problem. Particularly in the early stages, people with dementia may also have a depression, which may need to be treated. Behavior problems can be seen, and the personality can be completely changed. And this is so troublesome to families. So somebody who might have been so sweet, so nice all their lives, now have become mean and belligerent, maybe even swearing. And the family is shocked. And we're like, this is part of the disease process. Please don't blame the person. It's part of the disease process. Wandering can be very common and very destructive, because there have been people in Hawaii who wandered off and literally never been found. People can become socially inappropriate and show very poor judgment. Moving on then to treatment. These are the different stages of cognitive function. So here, this line down here is basically time from normal. And then this is a long phase, which goes over many, many years of pre-symptomatic. This is when people are in their middle ages, they're not even old yet, and already there are changes happening in the brain, but the patient feels fine and they're functioning fine. Then this is this prodromal, which is like a pre-dementia of MCI or mild cognitive impairment, and then full-fledged dementia. As you go up this line, it's normal to abnormal. So here, this purple line is basically functioning. This is activities of daily living. And you can see it's normal during this phase. Still pretty normal here. But here, when people reach dementia, that's when the functioning gets bad. Now they've lost their independence. And this green line here is cognitive performance. You can see it's pretty normal here. Here in the MCI, it's getting bad. So on testing, we see problems with their memory and other cognitive domains, but they're still functioning okay. Again, once you hit dementia, both are getting a lot worse. Prevention is most important, I think. We always want to do that, right? We'd rather prevent diseases than treat them. So preventive measures for the whole population, the things I talked about earlier, treating the heart disease risk factors from midlife onwards, staying physically, mentally, and socially active, having good nutrition throughout your life, recognizing people who are at risk early and watching them carefully, and then making that early diagnosis of dementia and treating those reversible causes. All of these are important. There are many safety issues. Medications are a big factor for dementia patients. Sometimes patients with dementia may forget to take their medication. So I call that underusage. So they've been told by the doctor to take something and they just don't remember, so they just never take it. Sometimes even more dangerous can be overusage. So we have seen people who've taken the medication not once, not twice, but 3, 4, 5 times because they forgot they took it. So they take it over and over and over and end up in the ER with an accidental overdose. That can happen as well. I really think medications for people with dementia should be supervised because it's so easy for people, it's so easy to have a mistake happen and it can be so dangerous. Over-the-counter medications can be very dangerous for older people. So when I have a patient who has dementia, the first thing I do is I tell the family, don't start any new medications without calling me. This could include cough and cold medications or pain medications or sleep medications over the counter. Many of them have something that actually lessens the level of acetylcholine. Remember I said the memory chemical, acetylcholine, is low in Alzheimer's. Some of these over-the-counter medications, Benadryl is the biggest offender of that. Benadryl is an anticholinergic medication. It actually lowers the level of acetylcholine. Somebody who has Alzheimer's who already has a low level of that chemical, now it becomes worse. So the Benadryl, instead of making the person sleepy, can make them completely crazy. It can have a very paradoxical reaction. Wandering is a huge problem. The Alzheimer's Association has this really, really good program called the Safe Return Program. They provide a bracelet or a necklace that the person cannot take off. On the back of it is an 800 number. You register the person in that Safe Return Program. You provide them with an electronic photograph, and they have a national electronic database. So even if you're traveling, let's say you go to Las Vegas and take your family member with you, and they wander off in Las Vegas and they're lost, you can call this 800 number, and it's good all over the country. Also, some states have a missing persons sort of rule that you have to wait 24, 48 hours to report somebody missing. If they're in this program so that the 911, when you call them, they know they're in the Alzheimer program, it's like an Amber Alert for a child where the search will start immediately. So there's no delay in reporting somebody missing. So I really encourage, if you have a person with Alzheimer's who is wandering, to put them into this program. Leaving the stove on. There have been times where people have had fires because of that. Leaving the water running, not quite as dangerous, but still can cause damage to the house. Driving. This photo says it all, right? And it doesn't mean that somebody who has Alzheimer's absolutely has to stop driving, but they need to be assessed very carefully. And I always tell the patient and the family, I'd rather you stop a little too soon than a little too late. And this is a little too late. So I'd rather that people stop driving a little too soon. These patients are definitely at risk for elder abuse and elder neglect. So we need to watch out for them. Even financial abuse. One of my colleagues wrote a really cool paper in the Hawaii Medical Journal many years ago talking about excessive sweepstakes participation in older people. And he found that many of these patients had an undiagnosed dementia, and some of them actually lost a lot of money. So again, focusing on early diagnosis to prevent all of these problems happening. So summary then, early diagnosis is key. Treat the cause if found, treat complications like behavior and sleep, provide a safe and stable environment, provide family education and caregiver support. Caregiving is the most difficult job in the world, and the caregivers deserve our support as well. It's really important that we talk to the caregivers separately so that we really get the truth of how they're doing. These patients need a whole team, not just the doctor. They need the nurse, they need a social worker, a dietitian, rehab therapist. The whole team has to take care of these patients. Community resources. In geriatrics, by the way, AA is always Alzheimer's Association, not Alcoholics Anonymous, okay? So Alzheimer's Association is a wonderful community resource. Executive Office on Aging with the Department of Health in Hawaii. They have offices on every island that can provide good resources as well. And then planning for future financial and legal issues. Our goals of care in dementia are very different. It's not to keep people alive longer necessarily. It's more to improve quality of life, to maintain independence and functioning as long as possible. Avoiding social isolation is really, really important. I have families ask me sometimes, we're having a family picnic this weekend. Should we take dad? The answer I usually give is, does he enjoy it? And they say, oh yeah, he enjoys seeing the grandkids run around, but next day he doesn't remember anything. And what I tell them then is, if he's enjoying it, take him, give him a good day, give him as many good days as possible. It's okay if he doesn't remember. If it's causing him to be agitated because it's just too much stimulation and activity, maybe then don't do it. But don't keep them just locked away in their rooms, give them as many good days as possible. And then providing care for the caregiver is really important as well. This is just a little plug for the Alzheimer's Association, the Aloha chapter. They have so much wonderful information. They have a good website. I put their numbers here. They have caregiver classes. They have support groups. We participate in those sometimes. We do a lot of joint education with them. They can even help with planning or counseling services. They do have that safe return program. And they also can tell you more about clinical trials in case you have a family member or friend who's interested. They'll let you know about all the clinical trials happening around the country as well. So with that, I'm going to stop my share and see if anybody has any questions. We still have about 5 minutes for questions.
So yeah, I have a question.
Sure.
So my family on my mother's side has dementia. I know my mom and her sisters. So I'm wondering, as you said, genetics is not usual, but is that the same as hereditary?
I'm so sorry, that was a little garbled. So did you say your family on your mom's side has a lot of dementia?
They all do, yes. And so I'm wondering if it's hereditary.
Okay. How old were they when they got their dementia? Were they younger or were they older?
Well, I know my family's in Australia, so I'm not really sure, but I think they were older.
Okay.
My mom is 80.
So if they were mostly in older ages, the chances are lower that it's the truly genetic dementia that I was telling you about. But if you're not sure, it's certainly worth talking to the doctors and asking whether they think this is a familial component or not. I can tell you for the most of my patients, it is not. It is usually those that have that very early onset dementia that I'm worried about the familial dementia. Somebody's asking me to put up the last slide again. So I am going to share my screen. And this one, I assume it's the Alzheimer's Association right there. I'll leave this on for a little bit.
So convenient. No need to carry cash.
I have a question.
Yes.
Can you hear me? Will there be a copy of the recording for us to obtain?
Yes, Michaela, we are recording this, correct?
How will we be able to get it if there are copies?
I'm pretty sure they are recording it. I did ask our staff to record it today. I'm so sorry, last week we didn't realize that you would want it, so we didn't record that one, but we are recording this one. And we will record the next one as well. I think we have one more to go.
And how do we get it? It's there, but
Michaela will
I-
send the link.
I will
Michaela,
send
will
the
you-
link. Yeah, I'll download it to YouTube and provide it to Pilates so that it can be distributed.
Thank you, Michaela.
Thank you very much for recording this session.
Oh, sure, no problem.
The first session wasn't recorded, but that was a good session also.
I'm so sorry we didn't record that. We didn't realize it would be necessary to record it. I guess from now on, we should just record in case. Yeah.
Yeah, this is a very good information.
Okay.
Thank you.
Any
so
other
much.
questions? Yeah.
Question. Can you hear me?
Yes.
This is the question. You know, it's kind of scary if doctors are not able to detect dementia early. So how do you detect dementia early? I mean, if it's not part of the exam, the annual exam, or, I mean, you're saying that now after 65, they're thinking about doing, you know, cognitive or some kind of screening, but
Yeah.
if we're encouraged to do early screening or early detection, how do we do that? Thank you.
Yeah, so fortunately, I think doctors are getting better trained on this now. So we have been doing a lot of training for primary care physicians. And so has the Alzheimer's Association. We actually partner to do this together. So we are really encouraging them and we're giving them the tools to do it and even offering if they need training for their staff. So we're trying to provide very simple tools. You know, the doctor is they have such short time with the patients, right? The primary care doctors, they often spend like 10 minutes with patients and they have so many other conditions to deal with. So what we're telling them is, you don't even need to do the screening yourself. You can train your staff. And then once a year for all your patients over the age of 65, have them screened. And then if there's a problem that they can bring it to you. So I think more and more now people are doing that. I think if you're not sure, if you have any concerns, if you are over 65 or for family members over 65, tell the doctor, I'd like you to do some screening. And then, you know, or refer me. I think most of the doctors have enough knowledge that they can at least do that quick screen. If it's abnormal, they may need to refer you out if they don't feel like they have the expertise in dementia. So I'll tell you, John A. Burns School of Medicine, every single medical student graduating from JAPSOM, since 2005, they have to do 1 month of geriatrics and palliative care. Every single student, no matter what specialty they're going into. You'd think with the aging of the population, this would be true of all medical schools. It is not. We are still one of very few that does this. So I think the medical community needs to do more. But I think on the patient side, you can ask. And you can say, you know, I went to a talk that suggested that people over the age of 65 should have memory testing done. I'd like to have mine done, or I'd like to have my mom's or dad's done, or whatever. So I think it's important for us to be proactive too with our doctors.
When you do such screening, how do they look for it?
So there are many different memory tests that are available out there. Again, a geriatrician or a neurologist may be able to do more detailed screening. For the primary care physicians, we're recommending these very simple tools. And there are a couple of them out there, and we just provide training for them to do it. The simple tests can take like 2 or 3 minutes. The more complicated tests will take about 10 to 15 minutes. So we're trying very hard to provide this training to encourage the doctors to do this.
What took away 2 years of pain?
One of our, Judith says, Alzheimer's Association has an office on Maui as well. and staff from there and Oahu have come to Molokai. That's absolutely true. I am not sure who the Maui rep is. I know the people on Oahu really well, but I think you can definitely just call them and ask them who the Maui rep would be.
These races are expected to predict.
I know that they have offices on other islands. It's just because I'm based on Oahu, I tend to know our Oahu people. They're the ones we do a lot of education with. But especially during this pandemic, I think not that there are many good things about this pandemic, there are not. But the one thing is all of us have now been doing a lot more distance learning, which means a lot more with neighbor islands. So that's one little good thing that's come out of this horrible mess of a pandemic that we've had.
It's ludicrous for any Republican to assert
Any other questions for me?
in safeguarding elections.
When will the next session be? When is it scheduled for?
I actually don't remember, but let me look. Michaela or Pilahi, do you remember?
I believe it's in December. It's in December. I'm not sure of the.
It is December. Yes, it is. Hold on, let me
I
look
think it's
for it.
December the 3rd.
Problems of future elections.
It's Friday, December the 3rd at 10 o'clock.
Thank you.
Sure.
I have
I
one
think-
more question. I have one more
Yes.
question, excuse me. I worked with Kupuna for a long time, and I've heard something along the lines of anesthesia-induced
Oh, yes.
dementia. And that kind of
Yeah.
scares me because I've arrived, I'm 66 years old, and I'm heading for another surgery. So it's like, I've
Yeah.
had several already. And I'm not too
Yes.
anxious about this one. So what is that?
The best way to.
Yeah, so actually they have found, particularly in certain types of surgery, the one that comes to mind right away is heart bypass surgery. Where you're under anesthesia, usually for a pretty long time, and you're on the heart-lung bypass. And they've done testing of patients and found that after the surgery, they have cognitive deficits that are new and sometimes kind of last a very long time. So what we do, I think it's worth inquiring with you. So if you're having surgery, I think it's important to talk to the anesthesiologist to let them know that that's something you're concerned about. We're working with the surgeons at Queen's to create a sort of geriatric surgery program to be more friendly towards older people. So we're working with one of the surgeons. Actually, it was the surgeon who had that idea. Give her a lot of credit. She approached us as geriatricians to say, can you help us come out with order sets that kind of decrease the risk for post-op, for pre-op, for things that we can do. So we're working together to try and figure that out. But part of that discussion is anesthesia. I usually recommend to people that talk to the anesthesiologist, particularly if you already have cognitive problems, but even if you don't, let them know of this concern. Sometimes they can get for certain types of surgery, they can get away with not as deep general anesthesia. So they could do like a spinal anesthesia, or they could do what they call sedation. So you're under very light general anesthesia, but not under the main general anesthesia, which has lesser risk. So I definitely think it's worth at least bringing up with the surgeon to say that that's something you're considering, that you're concerned about, and with the anesthesiologist to see, are there other options, that will reduce my risk, the type of anesthesia. Some surgeries, I think general anesthesia is literally the only type that they can do. So then you have to kind of balance the risks and the benefits of doing the surgery and not doing the surgery. But in some cases, they can actually avoid general anesthesia completely. It's definitely worth asking.
Look at in totality, you've got two different versions here. You've got the Republicans.
Any other questions?
Short of election integrity. You got the Democrats saying, well, hold on for a second. More rules, regulations means more voters.
Okay, well, you've been a wonderful audience. Thank you so much for your attention. And I'll see you in a little bit over a month, hopefully at our next session. Okay.
Thank you, Dr. Masaki.
That
Thank you,
session is
Dr.
going to be on
Masaki.
medication use in older people. So we'll see you then.
Thank you so
Thank
much.
you. Bye-bye.
Bye.
So on your way out, you have your little survey, just to answer a little, give us a little feedback on how today was. And then, does it also have oranges for you? We didn't give it to you earlier because we didn't want you to make a mess.